Virginia. And she's going to speak about her experience there and about and what we might take from her experience here in Canada.
Okay, thank you very much for having me. I'm delighted to be here. I am a vascular surgeon at West Virginia University in Morgantown, West Virginia, which is actually only a 6.5-hour drive directly south of Toronto, in case anyone was wondering. For my disclosure, just so everyone knows, I am actually Canadian, and I went to the States for my training. So I don't have much medical perspective from Canada because I left when I was 17, but I still consider myself Canadian. Otherwise, I do have some research support to disclose. No commercial interests, and objectives we'll just go directly to the talk. So amputation, as we all know, it's a devastating but preventable complication of diabetes and vascular disease. This is data from the United States. It's from the Amputee Coalition, which is a great website. April was Limb Loss Awareness Month, and this was one of their infographics that you could download and you could post to advertise around your community. So something you can go look at. I'm going to highlight just a few items from there. So some things that are very important that we already know, that people that have amputation have exceptionally higher costs over their lifetimes than people that do not, about $200,000 more in their lifetime. In addition, the United States in 2014, hospital charges alone for amputation was $10 billion. And there are significant disparities in the United States, particularly race-related, regarding amputation. And we're going to talk about that a little bit more, but non-whites in general undergo amputation at rates that are about 2 to 4 times higher than whites across the board. Amputation in general in the United States, the majority are due to vascular disease and diabetes. And that's unfortunate because 85% of all lower limb amputations due to diabetes are preceded by a foot ulcer, which means it's a preventable issue. To put our numbers into perspective, about 2.1 million people in the United States right now are living with amputation. This is the Mountaineers football stadium, which is in our hospital parking lot at WVU, and it holds about 60,000 people. So it'd take about 33 of these stadiums to hold 2.1 million people, and more than half of those will be due to vascular disease and diabetes, which means these were the preventable amputations. As already discussed by my colleague, amputations are a marker for mortality or a marker for an issue that has occurred in the primary care, primary prevention. So this is a marker for disease that's happening in the rest of the body. This is just showing us that there's something bad happening. And this is work from Dr. Armstrong, an editorial that discusses the fact that prognosis for somebody with an amputation is often worse than cancer. But if you look over about the fourth from the left, the neuropathic, or fifth from the last, neuropathic ulcers, you have about 40% mortality at 5 years. And then amputation, again, about 40%. Ischemic ulcer, about 53%. And definitely significantly higher than some of the major cancers that we deal with, like colon cancer, breast cancer, prostate cancer, etc. This is also echoed again. This is similar data, and this was the modern series because we constantly look at the data of the fact that someone that has an above-knee amputation has a 50% one-year mortality rate. And everyone's like, nah, this can't be, this not now, no longer, this can't be the truth. But this is considered a modern series from 2004. And again, it's the same numbers over and over again. So people that have a below-knee amputation have about 25% mortality in 1 year and then a 75% at 5 years. People with an above-knee, 50%. These are people with both vascular disease and diabetes. And again, it's because it's a marker for severe cardiovascular disease. What I tell my patients is, you know, if you can't get blood to your toe, imagine what's coming to your heart. And these patients typically die of a heart attack or a stroke. It's not the amputation that ends up killing them. Due to the fact that amputations are so preventable, it is considered a quality marker for diabetes care in the United States. And the federal framework for public health objectives in the United States, called Healthy People 2020, every 10 years they make a new set of objectives, and decreasing the diabetic foot amputations is considered to be one of those objectives. And this is just a chart showing from when they started in 99 at the beginning of this objective cycle. That was 6.6 per 1,000 with diabetes, and we're down to about 3.4 per 1,000. And so that's something they're tracking with a hope decrease. They always say like 10% is the goal they thing. They didn't officially set a goal for this one, but that's what they're aiming for. In addition, amputation disparities related to race and socioeconomic status are well documented. And this is again from the Healthy People 2020 website. And here you can see, so this kind of disparity, these blocks are the disparities. And so this is between non-whites, Black and African Americans in particular, and whites. And you can see here that you have 2.6 per thousand versus 4 per thousand as amputation rate. So again, this is a marker for a disparity in quality of care. In addition, socioeconomic status, so in the States we don't necessarily have the comprehensive healthcare system that Canada has, and so you can look at people with public insurance, which is things like Medicaid, which is for people with no insurance whatsoever, and versus other insurance types. And here you can see that people that had public insurance were 5 times more likely to have a diabetes-related amputation than people with private insurance. And so speaking a little bit more on that, I'm just going to talk about disparities and how people have been looking at those. And so geographic disparities is one way that people look at what's going on in amputation. This is a study done in northern Illinois, which is Chicago, which is where I practiced before West Virginia, by Dr. Feinglass et al. And what they looked at was, based on their zip code data, they looked at census-based amputations. And so what does that mean? So Chicago is a very segregated city. And so when you have segregation, this tends to highlight these issues of racial disparities. Here you can see, so blue is the majority Black neighborhoods. So these are greater than 80% Black zip codes. And then orange is greater than 80% or greater than 50% Black, so it's mainly Hispanic and Black. And then north side of Chicago, the pink is the white population. And so our zip codes are heavily segregated. And so what they did is they looked at the number of amputations occurring in each of these zip codes and then looked to see if there was any variation. What they found was that up top there, these are the Black zip codes, and that is, they had a 4 to 5 times higher rate of amputation compared to the white zip codes. So again, seeing a disparity, and this is both a racial disparity, but also a geographic disparity. And so echoing the idea, amputation is contextual. It's something that's happening in an environment around it. So there are other things at play. So speaking of these other things, looking at low-income areas. So there's a study from California that used some rudimentary mapping techniques that look what we call a choropleth map. So this is just basically a descriptive study. So they're showing colors and they're trying to make inferences based on colors. And we'll talk about this in my next talk when we talk about research in vascular. But on your left-hand side here, you can see the number of amputations per 1,000 people. And they had to aggregate it to quartiles. It's not that important. What's important is compared to where those low-income areas were. So there seemed to be a correlation. They did just a simple linear regression, and they're like, here, you can see this goes up. It's not, as complex. It's not a multivariable regression or anything, but you do see, you get a sense there is some socioeconomic issues happening here. And then finally, across the country, there's absolutely regional variations in the type of care that's happening. And this is a VA study, so Veterans Affairs, and so they're kind of a neat group to study because they're actually in their own healthcare system and they're tracked in this computer system for a very long time. And so researchers here looked at just the variations in major and minor amputation rates across the country. And you can see this is like a crazy output, but this quadrant system here, this is showing outliers. So there are major amputation outliers and minor amputation outliers, and part of what they saw was that areas where there were a lot of minor amputations tend to have less major amputations, and that could be a marker for foot care. But in general, what they showed was that across the country there were significant variations in the care that was being given. So to summarize, where you live matters. Perhaps you're in a rural environment where my patients live, where access to running water and very simple things is hard to get. Maybe you live where there's country roads and it's extremely difficult to get to the doctor. And we're showing the drive times, and that's something we're looking at as well, because especially where we are, you may be like 9 miles away from somewhere, but it may be a 3-hour drive or completely impassable if it rains. Maybe you're living in an urban environment where you are subjected to toxic chemicals or poor living conditions. Not the most important thing because you're worried about trying to pay rent. There's a lot of different things going on here. So I couldn't help but make a cool reference since I'm here from West Virginia. yeah, but yeah, amputation really, the canary in the coal mine. It's the marker for something else that's going on and something that we need to pay attention to. Part of my research looking at epidemiology and actually doing geographic analysis of where the hotspots of amputation are in my state, the other thing that we are doing is we're actually going and talking to the people that have the amputations in the state, and we're doing focus groups. And so I kind of skimmed through our preliminary data, and I came through some discussion points that I wanted to kind of get everybody involved in. I wanted to talk to you guys, so what are the most significant barriers to preventing amputation that you face in your practice? Now, we actually talked to a group of providers, and we have a few more on the schedule, of vascular surgeons and people that take care of patients, and we asked them, well, what are the things that you guys are facing that you think are the biggest issues in trying to prevent amputation? So this is the first slide. So here are some things that the providers came and talked to us about, just some things that came up. So again, patient awareness and education, they don't realize they're at risk. They haven't been taught foot education, looking at their foot every day, don't walk around barefoot, just basic things. There's an idea of apoplexy, which I had to look up the first time, but it is, there's too much stuff going on. And they can't take it all in, so it's like they don't care. But it's probably not that they don't care, but it's just they have too many other things that are happening in their lives, or they know that things are so serious and they just can't deal with that. Access to care, so that was something that was brought up, both economic access to care, also physical access to care. Adherence to recommendations, so offloading is a tough one to get patients to do. Getting them to quit smoking, getting them to take care of their diabetes, coordinating care, that's something that's a theme everyone's going to talk about a lot later today. And then also social and cultural barriers. In Appalachia, there's definitely a mistrust of large systems and of doctors in general. And that is something that you can certainly also see in other vulnerable groups of outsiders coming in and trying to make changes, and that's why it's important also to get people to actually make changes from within their communities. All right, so if you could be given anything you wanted to prevent amputation, what would it be? Sky's the limit. Proper footwear, yes. All right, so some ideas. If they could just quit smoking. If we could get out and actually educate the providers, because not all of us are that interested, right? Just teaching people how to do a pulse exam from a vascular perspective, or how to do a proper ABI. Then better communication between providers and patients. So making sure that patients are able to feel like they're connected to their providers, and making sure providers are talking to one another. Someone had an idea of in the States when, was it Bush had an aneurysm? You have AAA, and then all of a sudden, everyone over 65 could get paid to have free screening. So that kind of thing, wouldn't it be great if there was some celebrity to do that? Anyways, that was just solutions. Maybe we'll have time to talk about all that a little bit later. But anyways, key takeaway points: amputation is devastating but preventable complication of diabetes and vascular disease. Amputation is a marker for diabetes care quality. There are significant disparities in amputation related to socioeconomic status and race, and I'd also say rural status, but we're researching that. And that geographic variation in amputation is likely a marker for significant variation in access to the social determinants of health, which is what surrounds us. Thank you.